This podcast is brought to you by the Albany Public Library main branch and the generosity of listeners like you. What is a podcast? God, Daddy, these people talk as much as you do. Razib Khan's Unsupervised Learning.
Thanks for listening to the ungated version of the Unsupervised Learning podcast. If you want to read some essays on some of these topics, please check out razib.substack.com. Again, that's razib.substack.com. Thank you.
Hey everybody, this is Razib with the Unsupervised Learning podcast, and today we're going to be talking about genetics, but more in a news you can use, to quote the old U.S. News, tagline, sense than usual. We're not going to be talking about ancient DNA or anything like that. I am here with Halie May, who is a genetic counselor. Halie, can you talk about just your background, your education, what you do, where you work, that sort of thing?
Sure. I've been practicing.
Wait, I gotta say, you have a Substack too. So I'll put the link for the Substack everyone out there. All right.
Okay.
Yeah.
Awesome. Thank you. Yeah, sure. I graduated 6 years ago. I graduated from Sarah Lawrence College Genetic Counseling Program in 2018. From there, I started working at Columbia University as a research genetic counselor, and I played sort of a dual role. I did research for gene discovery. I also was a part of the faculty for the genetic counseling program there. And I did clinic as well. I did some kidney genetics clinic. After that, I worked at a startup company for a short stint, and then now I work at Natera in their oncology space.
Cool. What startup was it? Out of curiosity.
Called Tomorrow's Health.
Okay.
Yeah.
Okay. Cool. Obviously, genetic counselor, it's a little bit of tautology in terms of what that means to people. People have like a general idea, but can you tell just at the high level for people out there, and a lot of people, they're going to encounter a genetic counselor today, I think, in the United States, mostly if there's genetic disease in the family and they're about to have kids, I think, right? In the future, it might be different. But that partly depends on how many genetic counselors we have, that sort of stuff. But can you talk about what a genetic counselor does, like when you bring in a genetic counselor?
Yeah, I think you're right. I'm usually explaining to people what I do and what a genetic counselor is. And the people that do know what a genetic counselor is are usually people who have been through pregnancies before. So I think that's accurate. So genetic counselors broadly are clinical providers that work with the rest of the healthcare team to support patients through the genetic testing process. So that means everything from seeing a patient for an initial consult and taking a very thorough family history, seeing what conditions they may be at risk for, either based on their family history or based on any of their symptoms that they've had or any conditions that they've had in their lifetime. They will facilitate genetic testing, starting by speaking about the genetic testing options that are available to them, helping them and make informed decisions to make sure that they know what testing they're ordering, discussing the benefits and limitations of testing. Once the testing is complete, they'll be able to talk to the patient about the interpretation, whether that's a negative result, a positive result, or whether there's a variant of uncertain significance there, and loop in any other providers needed. They also can give a lot of great resources for patients. And then, of course, in non-clinical spaces, genetic counselors work everywhere from industry to research to start up a lot of the places that I described that I've worked myself.
Yeah. So I know what Natera does. I know people that work at Natera, but can you tell the listener what Natera does? Because it's a big name in genetics, but outside of genetics, it's not. So,
Sure. Yeah. Natera is a genetic testing company. They really started in the women's health space. And so again, when I say genetic, people know genetic counselors from working through pregnancies. They may be familiar with Natera's cell-free DNA test, which is commonly ordered during pregnancies. Natera has now branched out into the oncology space, and so I support their inherited cancer test. They also use cell-free DNA technology for a tumor detection test.
Yeah. So you said a variant of like uncertain significance, or people when they think of genetics, they often think of, okay, you get a test and it's like yay or nay, and I mean, like a baby should be able to read this test, right? That's really not mean, it's not, first of all, like when it is like that, it often goes through some sort of analytical pipeline, and stuff like that. But even the end result of a test, with things like base rate errors and all these other issues, it requires interpretation. Can you talk about the interpretive, like, what you as a genetic counselor, what genetic counselors often bring to the table, that sort of thing?
Yeah. So unfortunately, there are many times variants of uncertain significance, which means that there is a base pair of your DNA that's different than what we see typically in the majority of the population, but we're not sure if it's actually causing a condition. We're not sure if it's harmful or not. And usually it's because there's not enough information for that. So it hasn't been seen in enough people to be able to identify whether it's harmful. And so when you're trying to decide whether a mutation is harmful or not, or I should say variant, really, mutation is an outdated term. You're going to be looking at specifically the type of variant it is in the gene, because there are some genes, for example, where loss of function variants, where like it's something where the loss of protein function is going to be detrimental to the gene and then impair its function. There's other genes where it's actually gain of function variants that are going to be detrimental to the gene. So you want to see what type of mutation it is. You want to see where it is in the population frequency. There's major population databases, public databases for that. There's also internal databases in each lab. So they might use a combination of both. And then there's going to be the literature review and analysis to understand where this variant may have been seen before. There's also some analytical algorithms that can predict whether this is going to impact protein or not.
Yeah, I will say that the field, the field we're in, genetics, it's not like I don't know, like, let me give you something else. It's not like Newtonian mechanics. It's not like a science where you have like a book, you have a reference book, and you pretty much understand it. Maybe there's a few things on the margin. The last 20 years have been really crazy, and every time you talk to a geneticist, there's going to be new discoveries. That doesn't mean that everything is obviously overruled, but a variant that might be of unknown significance in 2018 may have changed by 2021. And so it's like you've always got to be checking these databases, right? Like that's part of the learning in the field.
Yeah, and what's interesting is there's not even a whole lot of consensus in that among clinical labs. There are some labs that will take that responsibility and will say that we will notify patients if we reclassify a variant. Natera does that. Not all labs do that, and a lot of times it is on the responsibility of the patient to be checking back with their provider, with their genetic counselor, to see if there's been any updates. So it's really dependent, and there's not a standard in the field, but it changes very quickly. Yeah, because studies are published all the time.
Yeah, I mean, just really, really quickly, I guess we should, I want to just define a few things first, so that, I think a lot of the listeners will kind of know what we're talking about in terms of variants. But just so you guys know, obviously, there's a reference human genome, and the reference human genome has 3 billion base pairs, most of which are not variable. A small minority are variable. Hundreds of millions. There's 100 million or so variants out there. So, Halie used the word variant because you don't know what that variant could be. It could be a single nucleotide polymorphism, most of them, or it could be a deletion, or it could be some copy number variant, some sort of structural variant. And so you use variant as kind of a catch-all term. And I'm assuming that she's trying to avoid the word mutation, or that's a word you kind of don't want to use because it makes it seem like the mutation is the weird one and there's the wild type. And actually, that's not always true. So I actually, like, as of this recording, I just put up a post about lactose tolerance, lactase persistence. And this is actually a classic case where initially it was considered a disease, or it was kind of considered a disease to be lactose intolerant. That turns out to be the wild type. That turns out to be the ancestral state, and 70% of the people in the world are lactose intolerant. And so they had to like flip it all back around. So the mutation is lactose tolerance. Now, that's not a disease either, right? And so that's why when you if you say, for the general public, in genetics, you would just say ancestral derived. That's the easiest way to say it. But like, what does that mean? So with the general public, you still use mutation, but it has certain connotations. When you say something is a mutation, it's not a great thing. But the reality is, it could just have a different function. it could have like no different function. It's like a silent mutation of some sort. And then you're talking about loss of function. Those are really straightforward, supposedly. It's like, okay, like the protein is like borked somehow, okay? Maybe it doesn't even produce a protein. Maybe it's a stop. But there are cases with loss of function, and Dan MacArthur's lab, he was at Mass General, now he's in Sydney, I think. They've studied people that have loss of functions that should, I think, be lethal, but they're fine. So,
Right.
So why is that? So like these are the sort of uncertainties that you're grappling with and have to communicate to people, right?
Right. And that's why a lot of times you can't really, there are some types of variants where you can't even properly classify it without a functional study or an animal model, especially, for example, if it's in the splice site region of a gene. That is something where you can't actually see if it's going to impact function unless you do a mouse model or something like that, or a cell model. So you're exactly correct. A lot of times you just don't know.
Do you want to explain the splice? Do you want to explain why splicing is a big deal? Because like like a lot of listeners are not going to know what that means, because that is a big deal. So like really quickly, a splice site. So like you have a genome. When you have a bacteria, you just read it. It just reads from DNA to RNA to protein, right? But in a complex organisms like us, and I'm assuming all the listeners are metazoans, you have splicing, which means that you take the transcribed, parts that translate into protein, and you can recombine them in different ways, right? And so that's why you get way more. The theory is, or the way they explain it, is that's how you get so much more variation and you're so much more complex. But your genome is like, a 30th the size of a lungfish. It's just on my mind because the lungfish genome just came out. It's 30 times bigger because of transposons. Whatever, it's all crap, but who cares? It's like impressive to people.
Yeah. Yeah. The splice site is that boundary between the intron, the non-protein coding DNA and the coding DNA. And so they're just slippery spots there.
We've been kind of getting a little bit into the weeds already, obviously, but I want to like take a step back. Like, you've been in the field, you've been in a changing field for a while now. In terms of the length of the field, like, it's actually not a trivial amount. Like, even if you think your career is new, you know what I'm saying? Can you talk about, like, have you noticed any changes just recently in terms of accessibility of genetics? You have companies like Natera, obviously you work through insurance and stuff like that, but these private sector testing companies like Natera, like Console, they're democratizing access to a lot of this genetic stuff, right?
Yeah, absolutely. I think that there is increased access to genetic testing services for a lot of reasons. I think that more providers are comfortable ordering genetic testing, are aware of how it impacts their field, and that will be different for different providers. Take oncologists, for example, and I guess that Natera is a company that makes sense here to plug as someone who has changed a lot over years and changed with the times and the technology. An oncologist is going to be very familiar with ordering genetic testing because variants in genes that cause different types of cancer or increase risk for different types of cancer can have management impacts. There are different types of therapies, for example, that are going to work better if you have a specific variant in an inherited gene. So I think that that's becoming more common practice. And so you'll get oncologists that are comfortable ordering inherited genetic testing and that are comfortable finding and knowing where to refer those patients to where the genetic counselors are. I think obviously there's the rise of 23andMe and some of the direct-to-consumer tests. Those were still out when I was in school, but more so even than when I graduated. And then there's the guidelines that have just been expanded and are more standard of care for more people. So prenatal guidelines, for example, and I called my friend just today who is a prenatal genetic counselor to check myself on this. When I was in school, NIPT, non-invasive prenatal testing, which is cell-free DNA, which is that test that I mentioned before. That's where Natera started in women's health. This is something that was only recommended for women over the age of 35 when I was in school. And even since then, 6 years ago, it's now recommended for all women, all ages, no matter where they are, as soon as possible in pregnancy. So that's a huge shift. And so you have OBs, GYNs all over the country ordering that because it's actually recommended by ACOG, American College of...
Okay. So yeah, this is like a little bit, like, I haven't kept track, like, the last time that I interacted with the OBGYN industrial complex was the mid-teens. So back then it was, they had just started coming out with NITP, these non-invasive tests, and that was it was recommended for 35 and older. Are you saying that's recommended for everybody now?
Yeah. So this is how it's stated, is that screening is recommended for everybody. That can be first trimester screening or quad screening, which were the old types of screening before NIPT came out, or NIPT. They do state that NIPT is more accurate, so it's the recommended one, but it can be any. It doesn't have to be NIPT. It can be any of those three. And so depending on where you go, there are a lot of institutions, especially in the metro area, which is where I'm based, where their first line is NIPT. That is the screening they're using. There are some places where it's still first trimester quad screen, but NIPT is listed there as a recommendation. Yeah.
Yeah, and this is just a blood draw, just to be clear for the listener, NIPT, right?
It is just a blood draw. Mm-hmm.
So back in the day, like as in like I don't know 2010, people used to do amnio and stuff like that, and that's like the scary, the scary needle in the woman's obviously into her uterus, whatnot. You get some sample, or and obviously there's a little bit of risk with that. NIPT is better because there's no risk, and you could get some. And so the goal is to get some of the DNA that's floating around in the mother from the fetus, right?
Yes, exactly.
And right now, it's mostly looking at copy number, or just kind of like chromosomal and copy number type stuff that's detectable, right? From what I remember.
It's mostly looking for aneuploidies, so extra
Yes.
chromosomes. Yeah.
Yeah, and so those are, I mean, even at like a small amount, you should be able to detect that sort of issue, right?
Yeah.
Yeah.
There are tests that have the ability to look for microdeletions. I think that the sensitivity of that varies very widely.
Yeah. And so let's talk about that. Like you're talking about sensitivity. Like these tests are, again, I think like the kind of like the caricature a lot of people have is like, oh, these tests are on off or whatever. But there's issues with the base rates and false positives and whatnot. Like, is that the multiple layering of testing? Is that how you get through that?
I don't know if I understand.
So basically, like, okay, so let's. What I'm trying to get at here is like there are some abnormalities that are very low frequency, right? And so the lower the frequency, you're gonna have like a higher false positive rate, just because like the tests have a baseline of making errors, right? So you have a base rate problem, and
Right.
so as it expands, because I'm assuming that as it expands to the whole, because like what you're making it sound like a lot of people are doing these tests, right? You're going to have a lot of false positives, right? And so, just like in your training, I mean, I know that you're at Natera now, but I mean,
Mm-hmm.
do you know like what genetic counselors are taught? So, for example, like if you get like a test that comes back true, like there are a lot of cases where there's like a 1/3 chance that that's wrong. So first of all, people should calm down.
Yeah.
Just calm down, because there's a 1/3 chance, like right off the bat, that you don't need to freak. But so I mean, how do you work with the psychology of that? Because like as a like I've never been a counselor type person, so I just like whatever, I'm chill. Yeah. But
Sure.
like dealing with the human psychology of people that have never had to deal with statistics and genetics and medical health, and then a lot of this is an OBGYN in a prenatal context. In the future, it won't be, but like right now, a lot of it is.
Yeah. That's a very good question. I definitely don't know the sensitivity or the diagnostic rates of NIPT off the top of my head, because that's not where I'm working right now. But like I said, it is known to be more accurate than the other types of screening, because it is based on the DNA. So, for example, if you're doing like a first trimester or a quad screen, those are going to be based on some hormone metabolites that they're looking at, as well as it's like age, and it's an algorithm. And so that's not nearly as accurate as actually looking at the DNA itself. So the reasons that NIPT can be off is if, for example, there's not enough cell-free DNA in the system. I think that can happen for different reasons. It could be just a bad sample. I think that there are issues of women with a certain BMI where the DNA may actually be a little bit diluted in the system. I think besides that, it's just generally, I don't know, understanding how to work with your patients and talk through numbers in different ways until you find something that resonates with them and sticks with them. Probably some genetic counselors find percentages useful. Some genetic counselors probably find high or low risk useful. Some genetic counselors may find other types of testing to compare it to help patients grasp it, because people certainly do have different scientific literacy and backgrounds.
Yeah, and this is like in one of the questions that I was going to give you. So I mean, let's hit it right now because you're at a company that's democratizing. I mean, obviously, you guys want there to be a lot of genetic tests out there. I mean, just it's a for-profit company, but I mean that's just a fact. There's a lot more tests out there than there were 10 years ago, definitely 20 years ago. It's just easier. And, just for the listener out there, I would say 20, 25 years ago, you didn't even have SNP arrays. You have to do these PCR tests. They're fine. They're very accurate, but, they're pretty, relatively labor intensive. Like you're looking at like one position in the genome and, somebody's going to be having to do the gel and all these things. It's very labor intensive. Today, you can get arrays that do, more than just what the NIPT does. And so, okay, you have all this data, you have all these tests. I know for a fact, I mean, just like I've talked to other genetic counselors about this, you guys, it's a high demand field because there's just a lot of, it's exponential, the number of tests that are going up.
Yeah.
And so have you guys thought about how you guys can make yourself more productive? So for example, I'm just going to throw it out there, like artificial intelligence, I'm just how can you guys actually handle all of the incoming? Because it's,
Yeah, I mean, I do feel like I need to stop just to defend us a little bit. I wouldn't say we're unproductive. I would say that there's just a lot of demand for us, and it's a small field, and it's a field that only started in the 70s. The first class didn't graduate until 1971, and so we're small and we're growing, and there's probably 20 more programs for genetic counselors than there even were when I graduated or was looking for programs 6 years ago. So we're definitely growing, and we'll be able to handle that. But yeah, as far as things that can help us with that workload, I think there probably is a lot of space for AI. I mentioned that we have this very thorough way of taking a family history. Probably that's something that AI would be able to do, is ask some family history questions. I'm sure that AI would be able to step in for writing clinic notes and annotating that kind of thing. I would imagine that AI could even step in and give back results, especially more straightforward ones. A lot of these prenatal tests that I'm talking about, NIPT results that are high-low risk, these are very standard tests right now. That would save genetic counselors time for the more complex cases where either there's more complex inheritance patterns, complex variants to talk about, or complex family situations, or just family psychosocial situations. So I think that where genetic counselors excel and where we can't be replaced, for example, it is in that psychosocial aspect. And it's in counseling a patient who just found out that they may have Huntington's disease in 30 years. And it's for sure that they will. And you need to talk to that patient about their fears and their responsibilities and how they're going to change the way that they live their life. And that is something that AI can't replace. Right now in my job, and this is not even a psychosocial situation, but there's a clinical situation where I'm acting as a liaison for a report where it's just a complex variant. It's a complex region of sequencing, and we're trying to figure out the classification. We're working together with the healthcare provider to figure out the classification. And that takes a lot of back and forth and asking the right questions and asking the lab the right questions and asking the provider the right questions. And that's something that AI can't do. So I think, for a lot of the more typical cases in the day-to-day, it probably will be very helpful. It's already out there. There's a lot of chatbots that are available, and there have been a lot of studies on chatbots that have been utilized in genetics clinics for pre-test counseling especially. I think that's probably the first thing that will happen is a pre-test AI model, which would mean that genetic counselors would be saved for post-test counseling, and that's the actual results interpretation and how this is going to impact patients' lives. Yeah.
Yeah. So okay. So you're talking about you're working on a project with some complexity. I actually have a question about most of the time what we're talking about here is because an aneuploidy. So let's say trisomy 21, Down syndrome, these sorts of things, right? That's straightforward. There's other cases where there's autosomal dominant, autosomal recessive. These let's just call it pathogenic variants of high penetrance. So okay, it's pretty clear cut. What if would you imagine that genetic counseling, it would ever be the purview of genetic counseling if you saw someone and you just notice, oh, they're in the top 1% of predict risk for type 2 diabetes. So I'm talking about complex traits.
Yeah.
I mean, like, so, I mean, is that even on your radar right now? I mean, I know you guys got a lot of stuff going on, but it seems like in the next 10 years, we will get somewhat better at this complex trait stuff. And as we go whole genome, it will be feasible, right? But obviously, there's, and like partly it's another question that I was going to ask you about doctors. My personal experience, and like I haven't done an ethnography on this, I've interacted with doctors. A lot of doctors, I'm just going to say it, like particularly the older ones, they don't want to deal with talking about genetics. Because like they have a lot to deal with already. They have a lot of reading and a lot of stuff to variables that they're juggling. It's just another variable. Can you talk about just how in terms of doctors are dealing with this, and also like again the future of other traits as we go into complex traits, not just like these autosomal dominant recessive, this like, maybe that's like 10% of the population, right?
Right.
But complex traits, like that's going to be everybody in some way.
Yeah, you're right. The complex traits are the ones with, I think a good example is diabetes. A lot of these things that are familial, and it's because there's a little bit of environmental impact, a little bit of genetics impact. But the thing is, it's not, there's no one single gene causing anything. It's a lot of genes that are impacting and influencing each other. So the technology that is being studied is polygenic risk scores right now. There are companies that are doing polygenic risk score reports. Natera may even do that in the future. I wouldn't be surprised. I don't know, but I think that's definitely coming. I think it's just a matter of, we talked about this before, of them being more sensitive and more accurate, and being able to detect that, which also means more data. We can't really be accurate on this stuff unless we have a huge pool of data to draw from to know what is typical versus atypical. But yeah, I do see that coming, and I'm sure that genetic counselors will be a large part in that.
So just out of curiosity, just this, I'm asking you like your impression, like what you know from Natera, just like your colleagues. Are the data are they looking at like array data, whole genome data? Are they looking at like other types of assays? Obviously, like 10 years ago, I wouldn't ask you if they're looking at whole genome data because like very few people did that. Today, it's feasible, right?
Yeah. I think that it's mostly GWAS data, actually. They're mostly looking at GWAS data and then honing in on those points that are, they hit a certain. Yeah.
So that would be mostly SNP array, like some of these like Illumina or AFI arrays. Okay,
Yep.
just because I'm trying to get a sense of the data, because like so because like that's like tens of megabytes of data for an individual, depending on how you compress it. Whereas like if you have whole genome data, I mean that's gigabytes of data, even with compression usually. So we are gonna. I mean, part of the issue, I think, this is like outside the purview of this conversation, but it like circles it is like it's an information technology conversation.
Yeah.
Because you're dealing with information, so the information technology that you have recourse to is kind of constraining and scaffolding like what you could talk about. Let me ask you, let me ask you really quickly about like some kind of ethics type stuff, because I know that is. I mean, so I went to grad school at UC Davis, and like several of the undergrads in my lab actually, they went to genetic counseling. I think they went to Irvine. I think people in California usually go to Irvine. Yeah. So, I talked to them just about like what they were interested in and stuff like that. Like, we were talking about like weird ethical, situations, and when I would talk to genetic counselors back then, when I was in academia, there wasn't a total unanimity. Like there wasn't like a clear answer. Like like what about like non-paternity events and all these other things? Or also like if you are looking because there's a familial history of this disease, and then you detect something else, do you tell them even though that's not being asked? How in your like education and just when you go to conferences, you talk to people, like how are people dealing with these sorts of questions, which are kind of like they're kind of spun out of the data. Obviously, that's not why you go into genetic counseling, but like they come out of the data, so what is your obligation or lack of obligation or what, right?
Yeah. By the nature of our job, because we are literally looking at people's DNA, I think there's a lot of these weird one-off cases that genetic counselors will get, and they're fascinating. And there's not a whole lot of guideline around this stuff, and there's definitely no duty to report or duty to warn. So it's really based on the genetic counselor and what they're going to do. I think that most genetic counselors would be forward to the patient and explaining these types of results I also think that the genetic counselors, and this is part of our training, we're very thorough in consenting patients and letting them know all of the things that can potentially happen if we are doing this test. Non-paternity is something that could come up, for example, sure, if you're doing like a whole exome sequencing where you're going to want parent samples because you're essentially comparing the proband or the patient DNA to the parent DNA. So you'll be able to see that. You'll be able to see if that data doesn't match because there will be nothing inherited from one parent. I don't think that that is happening so much in the prenatal setting because you're usually screening a baby. And so you're not looking at both parents' DNA at one time. You're looking at the baby's DNA. But for certain in a prenatal setting, for example, which I started this conversation by saying that I think I said this, carrier screening is also recommended to all pregnancies. Yeah. So if you're...
Yeah, we got that.
Right. So if you're doing carrier screening for an autosomal recessive disorder, it's possible that you could be a carrier for something that is also an autosomal dominant disorder, and maybe you just have a mild form of it and you didn't even know. So there are these odd things that genetic counselors come across. I think it's lucky that we have the skills and the training to be able to talk about this and not shy away from it, and really explain it to people and comfort them in just not only confidence, because we're able to explain why this is happening, why they maybe didn't know about it before, and how it can affect their family, but also give them the appropriate resources. Also, spend the time with the patient. I mean, genetic counselors have the privilege of sometimes spending an hour with a patient where maybe the physician will only have a minute as they're walking in the door and passing the room or something like that. So we're really able to give patients the time to sort through this information that we disclose, but it is really tricky.
Yeah, I will jump in here. I mean, my experience is like a little dated at this point, but I will say in the mid-teens, one of the great things about the genetic counselors that I dealt with is, because I have like training in genetics, I was like, can I see the results? Can I see the raw data? And we actually like worked through it together and
Yeah.
kind of like logicked everything. So they're very, my personal experience is they're very, if you're kind of the type of person that wants to, do it yourself and try to understand what's really going on, they're totally open to that. It's like, it's on your level. They'll meet you at your level, because some people, they want the final result, and they just kind of, that's like treating a genetic counselor almost like a doctor, because like a lot of times with the doctor, it's not like you're gonna like argue with the diagnosis. They give you the diagnosis, right? And so like that's one level, I would say. But I've like pushed it pretty far in terms of like getting like X-rays and like getting gels and all sorts of random things. And so I think like that's definitely doable. The listeners in here that are listening right now, probably like, I'd say like 25% probably, that have gone through the OBGYN system in a developed country. So a lot of the words that you're using, a lot of the things that you're alluding to, a lot of events, they have experience with. I would estimate like 3/4 of my audience right now has no idea. A lot of these terms, although they might like know on the surface level the terms, they haven't experienced it. So you were talking about carrier screening. We go in and they're just like, we're going to give you carrier screening. It's just like,
Right.
I mean, maybe we could say like, no, we don't believe in that. Like, we're the Jehovah's Witnesses of carrier screening. But basically, it's like, you're going to get carrier screening. It's not like a big thing. We're just going to do carrier screening. Okay, so like everybody who's probably gone through the process listening knows exactly what you're talking about.
Yeah.
In your view, like, so that's where we are today. 10 years down the line, in your career, I'm just kind of curious, like, I mean, how ubiquitous do you think genetics will be? Like, there's a lot of people, who are younger millennials, they avoid doctors like crazy. Actually, look, it's a big deal. A lot of people between 20 and 35 just avoid doctors, okay? This stresses them out. They're usually not sick.
Yeah.
You know what I'm saying? But so it's like, the idea of going to get a genetic testing, getting a genetic test in your 20s, it's going to freak people out. But some of the things that you're talking about, so let's talk about Huntington's, which, so that's like a triplet, disease, and, it could be coming off a mutation and it progresses over the generations. This is the kind of thing where you might want to know in your 20s, especially in light of the fact that medicine is improving. And there are certain drugs for many diseases where it's like, if you intervene early, it's better, right? And so I'm just wondering, 10 years down the line, how are you anticipating how geneticized, in terms of testing, the population is going to be? Like, how many of the people just on the street will have encountered your domain?
Yeah, I mean, I'm only speaking for myself here. I I can see genetic testing for all babies once they're born. I mean, we're already doing newborn screening, for example. That is standard, at least in the US. That's a federal mandate. It varies state by state, but we are screening for, and I think people know this, we're screening for conditions. They are rare disorders, usually genetic disorders, and we screen for them because there's treatment and because the baby will be in more danger if we're not treating it right away once the baby's born. So we're already doing that. And I thought this a while ago that I wouldn't be surprised if they're doing whole exome sequencing or whole genome sequencing for every baby that's born. I really felt like that. And I asked my program director that when I was applying to grad school even. And now I'm starting to see it. I'm seeing studies on it. I'm not seeing this in the clinic, but for sure, you go to conferences and you see studies on whole genome sequencing, either in the prenatal setting or, the patient asked for it. The patient started the process of the whole genome sequencing because they were interested in, and the yield, it's interesting. It's fascinating. You are getting results that would have been missed either with just the standard newborn screening that we're doing now, or just if you had done a smaller panel. There's whole genome sequencing, but then there are other studies. There's a couple of New York-based ones that are looking at a few hundred genes, for example, probably a few hundred of the ones that have a lot of rigorous evidence behind them. And so it could vary in terms of what genes will we actually report out. Maybe we'll only report out pathogenic variants in very well-studied genes. Maybe we won't report out everything, but I wouldn't be surprised if the backbone is there, which then means that the system will have your data.
Yeah, so I mean, I'm sure you've seen the study with infants that don't flourish, and the whole genome sequencing, right? So I mean, I think that was in 2017, 2018, and like from what I remember, it was a study where basically, because obviously newborns, those of you who have kids, have gone through the whole process. Some babies don't latch, and then they don't cry. Like there's all sorts of behavior patterns they're trying to figure out. Obviously, a newborn infant cannot tell the doctor what is wrong with them.
Right.
And so if you get a lot of signs, you got to figure out what tests do we do? How do we figure this out? So one of the pilot project I think they did was it was like a bunch of them, they whole genome sequenced them. And I think, and these are obviously a subpopulation that had something going on. They're babies that didn't flourish, so they had something going on. 40% of the time, and this was in 2017, I believe, 2018, they figured they detected a genetic issue that could be causing, which I think, that's a pretty good yield. I mean, yeah, we didn't figure it out 60% of the time, but hey, for those 40% of parents, that's great, right? So, I'm imagining that we're going to get better. And yeah, I mean, I do wonder what's holding, actually, I know some of what's holding us. I mean, we don't really have some of the capacity, which some of the information technology, when I've looked into it, we don't really have some of the information technology capacity to handle the throughput that we are, in our discussion implicitly talking about.
That's what I'm thinking. When we talked about this before too, who's going to analyze all those tests? Where is the data going to go? Yeah. Where in the cloud is it going to be stored? There's all these other more logistical things with that.
Yeah. So it's we have the technology, but we haven't put the investment. I will say I've heard Britain has talked about because they have the NHS, and the NHS is socialized medicine, so they own it all, from birth to death. Right. And they've talked about doing things like that and pushing, and they're actually, as Britain's big in genetics, and it's got a big history there. The issue is they have just fiscal problems right now, but maybe they have a new government in place, and who knows, they'll have a little bit more stability. They've talked about it. So, I mean, we live in interesting times. I mean, it's not as advanced as I would have hoped. I don't know, my listeners, most of them know this, but that my first son was the first human who was sequenced before he was born, right?
No, I did not.
Yeah, you could Google it. Yeah, it's the whole thing. Yeah, that's I did that in 2014. And so anyway, so yeah, I did it through chorionic villi sampling. It was whole genome sequencing. It was only 15x, but anyway. But yeah, he was reported in the media. You could just Google Razib Khan newborn, blah blah blah. But
okay.
Yeah. So I would have thought 10 years from now we would have been much further along. But I think part of the issue here is it's the medical infrastructure, the cultural buy-in. Because there are things Americans pay for. You know what I'm saying? I don't know, streaming. I'm just saying, like, we have technologies and we pay for it. We invest. Whole genome sequencing, I don't know if people necessarily think that there's I think part of it is the communication issue. I think also just, look, health and healthcare scares people. This was 23andMe, they did genealogical stuff partly because, it's not like a Thanksgiving or like conversation you want to have. Hey, I got you a BRCA test.
Right.
Yeah.
I'm just thinking about this now, but I guess because I'm thinking about how newborn screening, it does vary state by state. And so what federal agency would even make whole genome sequencing mandated or something that would be happening across all states, unless it was going to be some kind of national guideline like ACOG for screening. So I'm not even sure what governing body would come about for that. Or
I would think one way that so I don't know how it works. I know Medicaid is mostly about reimbursement,
Right.
but if Medicaid did reimbursement for that, that's like, I think 30% of births in the United States right there are probably under Medicaid.
Yeah, that's true.
So
well, I will plug this, and I think this is relevant to this conversation. Genetic counselors are not currently recognized providers under Medicare. And so there's actually a bill. There's the Access to Genetic Counseling Services Act, which I advocate for. And so it's true. It makes sense to me that if genetic counseling services are not necessarily something that are covered by genetic counselors as providers, that this is not something that would be widely distributed, this whole genome sequencing effort. So, but I think you're right. I think that that is something that increases access for most things. Same as, where is all this genetic counseling going to come from as there's an expansion of genetic testing? Well, we need to be reimbursed for our services before we can actually expand our services all across the country.
Yeah. I mean, it's not a public service. It's like, we live in a capitalist country. So, let me close out. Let me just I want to ask you about just the medical establishment and doctors and hospitals. And, I mean, you're at Natera, you're obviously in the private sector. It's a little different, but, you guys have to deal with insurance and reimbursements and all these things. How much resistance or just like confusion, what is the reaction? I'm an enthusiast for personal genetics, obviously. So I have like a biased viewpoint, right? I'm an advocate when I talk to medical professionals or when I go into, the doctor or whatever. But what is your general take on how because that's 25% of our economy, right? A lot of the issues that we're talking about, why we are where we are, have less to do with the technology and the science and more to do with the cultural attitudes. And so what are the cultural attitudes of the medical establishment to genetics and genetic counseling?
Yes, it's difficult. I think it's hard. As I said, genetic counselors are not recognized providers under Medicare, and it's a bill that we've been trying to pass for a few years. Myself, I advocate for genetic counseling licensure in New York. We're not actually licensed providers in New York State. That's state by state, obviously, as well. But that's something that we're really struggling to push and advocate for, I think, just because the need for it isn't understood. It is very hard to get services covered by insurance, and I think that insurance tends to lag behind the genetic testing technology available. And I am definitely not an expert on this, but I think that labs like Natera included, I think it's difficult to go to the insurance companies and try to get them to actually cover testing that is appropriate. Sometimes even when it is following the guidelines, a lot of these insurance companies are following guidelines. Some of those guidelines are out of date. So it's very difficult. And you're right. I think a lot of the barrier there is due to some of that policy, that overarching policy.
Here's what I don't get, and like I don't, you probably don't know either, but it's like with whole genome sequencing, we are hitting prices on the wholesale level that are like 100-ish, right? So if you look at your insurance bill, if you look at what they're reimbursing, sometimes $100 is nothing. So I don't really get it, But who's gonna store it? Who's gonna analyze it? Maybe I don't know what's going on here, but it's like it seems like at this point it's chump change. Like in 2010 or so, like $10,000, that's not a trivial amount of money. I get it. But now, like, so I mean, I'm whole genome sequenced, like my whole pedigree is whole genome. I just paid for it, Obviously, I can analyze the BAM file. I can do certain things. Most people don't have those skills. But why are we not like enabling the whole idea of democratization? That's what I mean. That's what I think what genetic counselors help with, like kind of like you're the link to democratize, because most people don't have a genetics education, right? They don't
Right.
know, but but they need, for their own decision making. I feel like within an hour you could get it across to people what they need to know, but
I
like
think yeah.
they need to have the data, and like we're just not there. And I don't know, I just it's a little disappointing, but
Yeah.
I guess that means that there's room to grow for your field.
I think there's room to grow. I'm sure that some of these direct to consumer testing companies will make it more affordable and more accessible to people in the future, which I don't have a problem with as long as people, again, are making informed decisions. And genetic counselors are always there to talk about those results if they need one.
Well, I mean, so let me ask you a last question. I guess like that was gonna be like the last thing I've talked about, but like I'm just talking to you, just like I've had discussions with genetic counselors. Well, I mean, I don't know, for like 15 years, just like more than 15 years. Partly because I'm just really interested in personal genomics. Like I've been, I did 23andMe in 2009. Stuff like that, and obviously with my son, whole genome sequencing. I just like I get ahead of the curve. So obviously I have like a personal perspective on it. But with genetic counselors, I have run into a full range of attitudes. So some people are very like into whatever. They're very like on board with the individual getting all their data and just kind of figuring it out. But frankly, other genetic counselors are much more paternalistic, in terms of well, like you don't want to know certain things, and how do you know you want to know, and
Yeah.
obviously, I'm not super aligned with that, but that is a position, and it was a consistent position that many people have held. And I'm just wondering, is that still is that division, or is that range, is that spectrum still there?
Yeah, the spectrum is certainly still there. I think that honestly, probably the majority of my colleagues would say that. I agree with you. I don't see the need to be paternalistic about it. I think that what's most important is empowering patients, is making sure that those decisions are informed. What I just want to make sure, again, I just want them to be properly educated. I don't think that they can't do it. I just want them to know what they're doing. So for example, if someone decides to get 23andMe, I'm not okay with them feeling like, oh, I've been screened for cancer now, so I'm not going to get cancer. See, that's not okay. But it's okay if they do understand and are educated on what they have been tested for. Then I see no problem with that.
Yeah. So I think that's totally true, because if people don't know how the statistics and probability work, I mean, it could be more dangerous to get a result that they miss. I mean, this is the position that I think a lot of genetic counselors that I've talked to come from. They're like, you put this information in people's hands, they don't know how to deal with it, and you know what I just say, what you just said,
Right.
educate them.
Educate them. Right.
So I think I think that that's where we're at. We got to like figure out how the education. I'm trying to do my part. I'm just putting it out there. Yeah. We all have to like do our part individually, because genomics, like, I'm a little older than you, obviously. It was like, in the 1990s, people didn't know if we would have a human genome before like 2020, because like they didn't understand what shotgun sequencing and everything like that would do. So we got it by 2000, the draft. We started doing genomics and all this stuff. And so now we have like all these like literally miraculous powers. You know what I'm saying? Like, if from the perspective of the 20th century, we have miraculous powers to understand our own genetic map, let alone somebody else's, something like, abstract genetic map. And so, we have all this information. What do we do with it? That's on us. That's on our society. And we just got to continue with the discussion. So, thank you for joining. I really appreciate just this update. And I think this is like definitely like a lot of listeners. I'm sure I'm going to get some follow-ups, whatever. But that's how it goes. A lot of listeners out there I know who are looking to have kids and stuff like that. All of this stuff is going to be very, very familiar. This is already part of the medical system in the United States. And those of you who don't have kids, I do think like genetic testing is going to start to creep into other aspects of your healthcare. And I know that you will start going to the hospital, or you will start doing your yearly checkups in your 30s. That just happens. It's a matter of age.
Yes. Thank you for your time. Thanks for inviting me. I think this was a great conversation. I appreciate that.
Yeah. Thank you, Halie.
This podcast for kids